Hi, good morning, everyone, and welcome to this week's Grand Rounds. Before we get started, just a few housekeeping tips. Please make sure your video is off and your mics are muted. Also, we ask that you please hold your questions to the end. In case there is time, you can unmute yourself and ask questions or use the chat box. Lastly, CME information will be in the presentation and periodically placed in the chat box. Thank you so much. So today our speaker is Dr. Cheryl A. Bedno from the Department of Occupational Medicine Service here at Rutgers NJMS, who will be presenting on military medicine and public health. Dr. Bedno is board certified in preventive medicine and public health and in occupational environmental medicine, and is currently the director of the Occupational Medicine Service. She completed her medical degree and doctorate in public health at the University of Illinois at Chicago. Dr. Bedno is also a retired veteran from the U.S. Army after 20 years of service. She has published dozens of peer-reviewed journal articles in her field, more recently in smoking cessation, and currently serves as a peer reviewer for several journals, including the American Journal of Preventive Medicine, the American Journal of Sports Medicine, and the Military Medicine Journal. We welcome you and thank you, Dr. Bedno, for joining us today to give your presentation on military medicine and public health.
Okay, good morning, everyone. Hopefully everybody can hear me. So today I'm going to talk to you about the military in general, military medicine, and a few topics I hope will be interesting to you and maybe something different that you haven't heard before. Okay, here is the CME information. Just give a few seconds there. Okay, we're going to start with a couple of photos. The photo on the left shows a soldier performing push-ups as part of a physical fitness test. The Army's physical fitness test is in the middle of a transition, but typically a physical fitness test would include the maximum number of push-ups performed in 2 minutes, maximum number of sit-ups in 2 minutes, and a 2-mile run. At least this is physical fitness test for the Army. And so for the push-ups, as you see here, and sit-ups, a grader is assigned and ensures that one is doing the exercise correctly and also keeping count. And on the right, we see 2 Marines participating in their training. And in recent years, we are fortunately seeing a greater focus on women performing similar activities alongside their male counterparts. Okay, here are the objectives. So my overall objective is to familiarize you with some military terminology, demographics, and then go into a few specific topics. And here is the agenda, some vocabulary, demographics, a little bit on the military and veteran health system, military public health. These are the special topics I'm going to discuss. And then very briefly on data and collaborative research. So when I talk to people who were not in the military or worked in a military or veteran environment, I quickly realized that the military has its own language and vocabulary. This is just a few terms that I think you should know as we go through the next slides. The Department of Defense or DOD includes the Army, Air Force, Marines, and Navy. And then the Coast Guard actually falls under the Department of Homeland Security, except during wartime. Coast Guard then falls under the Navy, but Coast Guard is included as categorized under armed forces. A veteran is somebody who served in the military and then was discharged or released, and then a retired military veteran, someone who spent who served in the military and spent 20 years or more, or was honorably discharged because of a physical disability, and they're sometimes referred to as being medically retired. So I added in this slide about rank, just because we're going to be referring to rank in a few slides. And I was in the military for over 20 years, and I don't honestly know the rank structure of each of the services. And so I'm not going to spend much time on this. And just to know that ranks, specific ranks differ by service and are separated into enlisted and officer ranks. And then just also officers include warrant officers. And these are officers typically that are highly specialized or have technical expertise, and also include aviators. Basic pay is standardized across the military according to pay grade. So an E1 or a PVT or private, which is the lowest Army rank, will make the same amount of money as an E1 in a different service. So it's standardized based on pay grade, years of service, and then there could be some additional pays depending on the job of the individual. So in today's all volunteer military, there are about 1.4 million active duty, with the largest proportion being in the Army. And then you can see at the bottom of the slide, in 1968, there were 3.5 million active duty during the military draft era. So the number and the proportion of active duty, has dropped rather significantly over time. And so with the 1.4 million, this is about 0.4% of the US population. And the data in this table and the subsequent tables are current as of August 31st, 2021, and data were obtained, and they're actually publicly available from the Defense Manpower Data Center. So as you can see, the military is largely male, but there are differences by rank and service. So you can see that the Marines have the lowest proportion of women at overall about 9%. And the Air Force has the highest. And then in reviewing, the table and looking at the Army, the proportion of women decreases as rank increases. So almost a fourth of the lowest rank officers, which are second lieutenants, are female compared to the highest ranking non-general officer, which is the colonel at 13.2%. And interestingly, general officers, so these are brigadier general all the way up through your 4-star generals, across the services are about 9% female. Now, I do want to mention a little bit about National Guard and Reserves. These are individuals that typically have regular day jobs and then drill or train 1 weekend per month and 2 weeks per year. The National Guard consists of the Army and Air Force National Guard, and each state, territory, and then the Washington, D.C. has their own National Guard. And there are approximately 445,000 soldiers and airmen in the National Guard. And then each military branch has their own reserve component. So those actually belong to, so for the Army Reserve, they belong to the Army. So it's a little bit different structure than the National Guard. And so similar with the National Guard, they fill in, when needed or augment during, special needs of the U.S., either within the U.S. or overseas. And you can see the total reserve population is about 350,000, with most of that being Army Reserve. And before I finish up with demographics, I would like to mention civilian personnel because they serve very important roles in the DoD, especially in healthcare or hospital settings. And you can see the total, which is significant at over 730,000, and that includes the service-specific civilians as well as what's called a DoD civilian. So in my former department, probably 80 to 85% of our staff were civilian, and I think that's pretty typical. In a lot of the hospitals in the DoD is the significant number of civilians. And just to mention that these are only probably the largest part of the civilian population, but there are other civilians who work in military settings who are not appropriated. So their funding comes from other sources. And then there may be civilians who work for other organizations or even contractors. And so how many veterans are there? So these aren't active duty, these are the people who have served, and there are over 17 million. And then in the chart on the right, you can see that the composition of veterans is changing over the next few decades. There will be fewer from the Korea and Vietnam eras, and most will be from the Gulf War or post-Gulf War. And then there will be a greater proportion of Hispanic, Black, and Asian veterans, as well as a greater proportion of women. Okay, some more photos. I'll have to admit the photo on the left does not necessarily bring back great memories for me. These are soldiers at the range. So they're there to practice, firing their weapon. Most military are expected to go to the range periodically, and that frequency depends on their job and where they're assigned. And that includes military physicians. These soldiers are using what's called M4 rifles. And then you can see soldiers standing in the background that are there to ensure that the whole process is done safely. And you can see there's somebody there with a red flag that is there to also ensure safety. So the photo on the right depicts one of the Special Forces training events. This one's called Robin Sage and takes place in North Carolina. And since public health, a lot of what we did was deal with COVID. Training events such as the two that you see pictured here, continued to occur during that COVID environment. So there had to be a balance in mitigating COVID risk and carrying unnecessary military training. As you can imagine, this was not easy. Okay, so since most of us are healthcare providers or physicians, and some of us may have worked or work in the VA, I'm just going to kind of talk about both systems and some differences. Again, this is going to be a really quick overview. So the military and VA systems are separate, but there are some linkages. In some places, military and VA hospitals may be co-located, or there may be some collaboration on various services. In some cases, veterans may be able to use some services in a military hospital, and then certainly some retirees can use the VA. And I do want to mention, since I have been spending a lot of time dealing with electronic health records, the military and the VA are in the midst of launching a new health record, and it's been a kind of a slow launch in various places across the US. And that system is called Genesis. The intent is to provide a single health record for service members, veterans, and their families. Okay, I'm just going to do an overview on each of them. So starting with the VA, the VA health system is pretty vast with about 1,300 healthcare facilities, including their large medical centers. And not everybody who is served in the military is eligible for care at the VA. Eligibility is based on priority groups, which are informed by military service history, disability rating, income level, and so forth. Some veterans may have to pay a copay, and some may not be eligible at all. And I just add in a picture of a large VA medical center in Illinois. Next, we'll go on to the military health system. So the military health system serves active duty retirees and their families, either through a military treatment facility, kind of a large medical center, or a military clinic, or it probably in most cases, and the greater proportion is network civilian providers. And you can see some of the numbers of the military facilities. So about 49 hospitals or medical centers, 32 in the US, and then several hundred clinics, dental clinics, and then about 250 veterinary facilities falls under the military health system. And TRICARE or Humana Military provides healthcare benefits for uniformed service members, retirees, and their families. And then, you know, pictured there is Womack Army Medical Center, which is where I worked before I came here. One of the larger medical centers in the Army, located in North Carolina. So as a public health physician, I could not do this presentation without mentioning public health in the military. And although there are some commonalities, the type and size and scope of services differs by service and installation. So larger installations, especially with a large medical center, will have a wider scope of public health services. And then you know, a smaller clinic may not have, you know, the full set of services, or it may be scaled down a little bit. So on the Army side, there is an effort to have each installation public health department accredited by the National Public Health Accreditation Board. And there are about 28 Army public health departments. And so far, 2 of those have been fully accredited, Fort Riley and Fort Bragg, where I came from. And this was a big part of my work when I was recently there. And because I'll be referring to some of the public health services when we get to the special topics, I just want to talk about what services there are in a typical Army public health department. Epidemiology and disease control, public health nursing, occupational environmental medicine, hearing conservation or other hearing services, Army Wellness Center, radiation safety, otherwise known as health physics, environmental health, and industrial hygiene. Okay, now I'm going to go on to some of the special topics, and I tried to focus on topics that I thought would be relevant to the group or something new or you didn't know, but I'm really providing a short overview on these topics and just hitting a couple of points, but so there may be questions as I go through these things really quickly. So medical requirements for accession. And so I do want to mention, you know, what is accession? It's another one of those kind of military terms, and, you know, accessing into the military kind of means what those requirements is what's required to get into the military. There are many steps and requirements that go into getting into the military successfully. And going into the details from recruitment onward, this is beyond the scope of this presentation, but at least on the medical side, screening occurs in one of two pathways, either through the MEPS or through DOBMER. Again, military loves their acronyms. So for enlisted personnel and some officers, in particular healthcare officers, goes through one of 65 MEPS, Military Entrance Processing Station, and they're responsible for the medical screening. For all of the other officers, they will go through the DoD Medical Examination Review Board. And so typically these are going to be your other officers like ROTC, the service academies like West Point or the Naval Academy. They will go through this process, and DOBMER contracts out their medical screenings to several hundred locations throughout the US. So these are two, separate processes, but there should have some commonalities. As you can imagine, the medical screening process can be a little tricky because some applicants may be fearful of disclosing some parts of their medical or mental health background for fear that it would lead to them being disqualified or not in the military. Based on the needs of the military and the military services, standards, could be loosened or tightened. So for example, if there's a need for more service members or soldiers, the services may look at which of the standards could be a little bit more lenient without causing risk. And then earlier in my career, I had the opportunity to participate in this process to review Accession medical standards. And there's a lot of discussion, expertise, and data that goes into that process. So I'm going to hit quickly on retention medical standards, and we're going to get into an example. So these are standards to retain service members on active duty. So standards take into consideration the job tasks required of a soldier, airman, Marine, etc., and whether the potentially disqualifying medical condition poses an unreasonable requirement on the services. So this is very similar to what we do in occupational medicine, with fitness for duty or a reasonable accommodation. So it's looking at, that medical condition and those job requirements. So now I'm going to go into an example of an accession and retention standard. So the first one, this is the accession medical standard for diabetes, and I just copied and pasted this directly from, it's kind of our regulation, the DoD instruction. And so I'll kind of let you, read this as far as the standard. Again, this is the standard to get into the military. And so you may think, does this mean that somebody with diabetes or meeting the criteria on the slide cannot join the military? No, so, if somebody, has a disqualifying condition, they can be granted waivers, and those waivers are granted by the service, by the Army, etc. And again, sometimes this is based on, the needs of the service. They need more people. They may be more willing to accept people who have documented medical issues. And then let's look at the retention standard for diabetes. And I will let you read through the language of the retention standard. Give you a couple seconds. So as you'd expect, there are service members who develop diabetes type 1 or type 2 while on active duty. And then you may ask, can a service member who is on insulin be retained or serve on active duty? So, the answer is, it depends and possibly. The service member needs to be motivated, and the medical team needs to work closely with that soldier and to leverage the technologies, remote monitoring, et cetera. Some of these service members can, even be deployed. There have been, some, real successes on being able to manage a service member on insulin, and with success. I put one of those articles detailing the successes in the footnote of this slide, but there have been other such reports. Okay, the next topic I'm going to discuss is body weight and obesity. So in recent years, there's been a lot of attention. It's been in the press quite a bit, because of the significant number of individuals, especially younger individuals, who are not eligible to join the military because of obesity. The bottom picture, and this is a kind of infographic from the CDC that what are the three most common reasons that people are ineligible to serve besides obesity. The others may be education or a criminal record or drug abuse. And these things affect achieving recruitment goals, which I'm going to go into on the next slide. So there was, even, a couple of months ago, there was a Congressional Research Service report describing the challenges of recruitment, especially with the increasing proportion of obese youth. And just from a few months ago, there was a report on NPR that said across all segments of the military, 31% of young adults cannot enlist because they're too heavy, according to the Department of Defense. And so with the need to recruit about 175,000 enlisted personnel every year, this, has some challenges. That same NPR report spoke about recruiters kind of taking on the role of coaches and helping those younger individuals who want to join the military with losing weight and learning about physical fitness. And also, most military applicants are from the South, and the South tends to have higher obesity rates across the U.S. So this is, part of the challenge. And like with everything in the DoD, there are standards that specify physical requirements, including body weight and body composition. And there could be some differences by service. Okay, I'm just going to go into a little bit about those standards. In general, the standards are based on age and gender. The Army, for example, has a two-tiered system for body weight assessment. First, height and weight's taken. And if you exceed height and weight, then a tape test is performed to determine body fat percentage. Men are taped at their neck and waist, and women are taped at their neck, waist, and hips. And just as a side note, I read that the Army is currently doing some studies of the use of the tape test as a best, if it's a best measure of body composition. You have to think of what's, when you're doing thousands and thousands of people, there's more sophisticated equipment, but when you need to do something that's not very expensive and can be rolled out, across, globally, that is part of the challenge. And I think why the tape test has been used for so long. Okay, this next slide, I'm going to show you some of those, the weight limits and body fat limits, you know, for men and women at different ages and different heights. So an 18-year-old male who is 70 inches has a weight limit of 180 pounds. And if this is exceeded, then he is taped, and his body fat, his tape test is done, and his body fat limit is 20%. An example for a female, an 18-year-old female soldier who is 64 inches, cannot exceed 145 pounds. And then, you know, similarly, she is tape tested, and her body fat limit is 30%. And I'll let you kind of review the table and the entries for those. Okay. So you might ask, what if the soldier exceeds body fat limits? You know, like with everything in the military, there's a program for that. In this case, it is service specific, and I'm going to talk about the Army. So on the Army side, if a soldier exceeds body fat limits, the first thing that happens is, you know, the results are verified. If indeed that person exceeded body fat limits, the soldier is enrolled what's called the ABCP, or Army Body Composition Program. It's probably the 20th acronym I've given you today. So that program has multiple steps and includes, these are just a few of the things that this includes, is evaluation by a registered dietitian, regular body composition assessments, an optional medical evaluation, and then evaluation by the Army Wellness Center, which in the Army Wellness Center is part of public health on the Army side. And so Army Wellness Center does metabolic testing, fitness testing, body composition analysis, and education and coaching. Those soldiers who are in the ABCP are flagged. And so, you know, what is a flag means that that's kind of in your personnel record, that you cannot get promoted, attend professional military schools, or have certain higher level assignments. And, you know, that flag is later removed if you come off that program. And so the soldier needs to show progress in losing weight and to ultimately meet standards. And if not, that soldier may not be able to continue serving in the military. And I just want to note that pregnant soldiers are temporarily exempted from these requirements, and they have, I think it is now 1 year to meet those requirements. So, you know, so what are the consequences, or, you know, why is this important? You know, there's multiple studies have been conducted on this topic. And I mentioned 2 studies that I was involved in. So one is 2017, and we worked with researchers at Stanford involving large data sets, kind of big data. And we found a greater likelihood of lower extremity musculoskeletal injury among men who were underweight, overweight, and obese relative to the normal weight. And those findings were not statistically significant among women. The other study I want to mention, excuse me, was the assessment of recruit motivation and strength. So this is an older study, but deemed to be a very successful study. It was an Army pilot, which was later expanded into a program. And so what did this study do? It allowed soldiers to enlist without meeting body fat standards if they passed a pre-accession fitness test at one of the MEPs. And so this waiver was was called the body fat weaver. And there was a ceiling to that, so not everybody could enter, and there were some qualifications. And so they had to do a fitness test, and that test consisted of push-ups within 1 minute, and there was a certain number to be achieved by men and women, and a modified Harvard step test. And not sure how many of you are familiar with a step test, but it's like it is. It's, stepping up and down, and you had to maintain a certain pace at a, within a certain heart rate. So this was done initially at a couple of MEPs and then expanded. And so people could pass this test, they were allowed in. And then we followed them, and we studied numerous outcomes: attrition, whether they could successfully serve, injuries, stress fractures, heat injuries, and so forth. So the ARMS program was found to be effective in identifying soldiers who could serve despite exceeding body fat standards. Would mention that there were some risks, including some higher numbers of various injuries, et cetera, but overall found to be a successful way to bring more military in. So I could talk for hours on some of those studies, but I'm going to move on to our last topic. So HIV and sexually transmitted infections. So HIV can negatively impact mission readiness among service members. And because the military regularly gets tested, and service members can serve if they are positive, the military often informs civilian guidance on HIV testing, et cetera. Since 1986, there has been some screening in place. And in 2004, the Department of Defense established HIV screening every 2 years. So service members are tested frequently prior to joining the military, every 2 years, before and after deployments. And then as recommended as part of preventive medicine services, if you're testing positive for another STI like gonorrhea or chlamydia. So I'm going to show you some data on the next slide. So these are new diagnoses of HIV from 2015 through the end of June 2020. So these are fairly recent. So during this time, you can see at the bottom row under total, the total HIV tests, about 2.4 million tests. The number of people tested was almost 2 million. And then you can see the total new HIV among all those tests was 396 positives among the about 2 million people tested. Most of those positives were male, 388 versus the 8 female. And then of these positives, at the time that the data were collected, about 245 were still serving in the military. So I'm going to talk a little bit about this on the next slide. So first, I want to talk about the notification process, and then I'll go into what happens when somebody is HIV positive. So the notification process is the lab notifies the installation's public health department. And again, this process is for service members or soldiers only. This does not apply to beneficiaries who are treated kind of like everyone else. The public health nurse serves as the HIV manager, contacts the soldier, and makes an appointment for notification. At the same time, the soldier's commander is also contacted and comes in and accompanies the soldier. The preventive medicine physician or provider meets with the soldier and notifies that person of their positive test, and provide standardized counseling, etc. At the same time, the public health nurse talks to the commander, lets the commander know, answers any questions. There's a big emphasis throughout the process on the importance of confidentiality, and only the soldier and his or her commander are told. The public health staff conducts, contact tracing, et cetera, obtains additional labs, and then from then onward, there's a close working relationship with infectious disease, especially for follow-on care and treatment. And so this is the Army, but there are similarities with how the other services conduct it. So can you be HIV and be in the military? So to enter the military is a disqualifier, and I'm not aware that there are any waivers. So if a service member tests positive while on active duty, they may be able to continue to serve in the military as long as they can fully perform their military duties. And, as I showed on the previous slide, there are a significant number out of that total that were still serving in the military. Some services do impose limitations on what the service member can do. For example, they may not be able to deploy or participate in some other assignments, such as contingency operations. And again, a lot of, what I'm saying is specific to the service, such as Army, et cetera. So just on risk factors, the trends for HIV tend to mirror what we find in the civilian population. Most of the HIV positives are men, men who have male-to-male sexual contact and who are African American. The military services have programs to provide education and reduce the risk of HIV. For example, most clinics have PrEP clinics, pre-exposure prophylaxis, and so forth. We get a lot of our guidance and collaborate with the Military HIV Research Program, MHRP, which is part of the Walter Reed Army Institute of Research. And they do a lot of research on various aspects of HIV, including the US military HIV natural history study, and then studies, other studies in the US and overseas, including some of the overseas sites in Thailand, Kenya, and others. And I know us at Fort Bragg have been involved in a couple of studies with MHRP. So I want to mention a little bit about STIs, and this slide you see here is from an article that was done by NPR. So this is from, I think, late 2019. And the reporter interviewed people across the US on STIs, including my department at Fort Bragg. The headline photo was one of our civilian providers who was conducting training to soldiers on STI prevention using what she calls STI, jeopardy. And so the intent of this was there had been reports in the news about the growing number, the rising numbers of STIs across the US, including in the military. So, like I mentioned with HIV, STIs can adversely impact service members' availability and ability to perform their duties, and can, of course, lead to serious medical sequelae. The most common are chlamydia, HPV, gonorrhea, HSV, and syphilis. And again, trends and risk factors mirror those in the civilian population. And there's a big emphasis in the military on education, screening, and follow-up. And with HIV, with HPV, the military does not require it. It is only recommended in the military so far. So a few charts. The first one is the chlamydia incidence. And the red is females, the light blue is males, and the dotted line is the total. So we can see that among military women, the incidence is much higher than men. And there have been increases since 2013, but into 2019, we see some decreases. And I'm going to go into the next slide, which is gonorrhea. Again, we see a similar pattern. If we look at the dotted line overall, the gonorrhea incidence increased from 2011 and then started decreasing. And you can see some of the differences between men and women. Just to talk a little bit about what is involved in STI screening and reporting in the military. Because of regular health assessments and free medical care, military have really ready access to STI testing, and women overall are tested more regularly, especially those 24 and under and with risk factors. So sometimes it can be difficult to compare military and non-military STI rates because of the differences and the amount of testing involved. If when there are positive results through a military lab, the public health department is notified. Public health conducts follow-up, treatment, contact tracing and notification, and then military and civilian disease reporting, and we were required to notify to both. And just to also mention, military installations have their own, tend to have their own standalone STI clinic or preventive medicine clinic where people can go for more confidential services. And although there's good capture of STIs, some military personnel seek screening and treatment through civilian health departments or other locations for whatever reason. Okay, and this is my last slide. I just want to briefly mention data and research. You probably kind of saw from the various slides that the military collects a lot of data. And part of it's because of the reporting requirements, and there's also the one payer system. So there's quite a bit of healthcare and public health data. The administrative and demographic data, much of it is maintained by the Defense Manpower Data Center. Because of the access to data and a pretty easy to access group of potential research participants, many civilian researchers want to work with the military, and then vice versa, many military researchers want to work with civilian partners. And part of that is the military does not typically have dedicated time to do research, and so they look for non-military partners to help with grants and also expand expertise. So this is something that some of you may want to consider if you have a topic, because there may be military physicians who are looking for such a collaboration. So I'm going to move on to my last slide. So I hope my presentation gave you some initial information related to military and public health, public health and medicine. I know many of you work at the VA or will work at the VA, so hopefully this will be useful. I want to thank the preventive medicine residents for reviewing these slides and giving me comments. I'm not sure if anybody can guess where this this slide was taken. So this is actually Afghanistan, and I took this photo flying between Kabul and Bagram during a very snowy winter. And then I'm going to add the CME information in the corner, and thank you for your time.
Thank you, Dr. Bedno, for a really extremely informative, insightful, thoughtful presentation discussion on the military public health, and it certainly sets stage to think about public health generally. And also just to acknowledge, as Dr. Bowen did at the very outset, your service. And for those who don't know, Dr. Bedno was a full colonel when she retired from the U.S. Army. There's some time for some discussion. Maybe I can just lead it off and ask. It's really interesting. It's really very interesting to see the detail of the public health considerations, which, as you presented, may seem obvious, but of course, it's really a lot of thought and careful attention to the public health of a very large group of people. When you look at that, and if we take an organization like a university such as ours, are there things that we should be thinking about and doing in a large organization that really we can learn from what's done? I was struck very much by the whole discussion around obesity, for example, which we know is really a huge health problem in the country, and how much work is done in the military and the screening, the careful attention to it. That was one area that I was struck by. I'm just curious what you think about things that can be brought forth from public health in the military to large organizations outside.
Well, I think there's a couple things. I've been thinking about, where could, I think one big difference is, first off that, at Rutgers, there's no central public health area. There's occupational medicine, there's student health, but no kind of centralized body that puts forth guidance. A lot of what we did, and I think could be more useful in an environment like Rutgers, is working really closely with individuals who can get out the information. On the military side, it's like a public affairs, or on the county side, it's public information. But we spent a lot of time working with those communications experts on getting out messaging. And I think there's a real gap in what are those resources, and how can you get them? So I think that's something where we could probably learn from the military about, because there's a lot of services available at Rutgers, but do people know about it? So I think that's one thing that can be learned from the military. For example, with obesity, there were, you've got TV screens and people sitting and waiting. Well, there could be information that an individual could read. So I think getting out a lot of the public health messages and programs is one thing to start with.
It's really interesting. Thank you. Please, anybody, if you want to either put it in the chat, we certainly can do that. We have that on the screen here, or if you want to just raise your hand. Dr. Cespedes, who heads up our weight management center. Thanks for a great presentation. How has the military been adopting the use of anti-obesity medications? That's a relatively new addition to the health armamentarium.
So that's an interesting question. And, since, I'm not currently in the military, but I think use of some of those medications was not authorized. But I think it depended on what it was. I know there were issues with, some service members would go out into the civilian community, they needed to make weight, and they may try and take, various medications which either approved or not approved. But I'd have to look into that to see if they are kind of on the, you're not allowed to do that or not, but that's a great question.
Thanks. Another question that also involves, I think, a very current topic, but again, Dr. Bedno is not running it anymore, not running that, but about refugees. We used a lot of refugees from Regina Bavru. Can you comment on the structure of medical services for refugees arriving on military bases?
That I cannot speak to. I do not have that expertise. That's a great question.
An issue at hand at the present, right? Sure. You know, it's very interesting to see what you showed about STIs, and again, affects the younger population, as you noted from the outset. But there was this rapid rise, in the early 2010, 2017, 18, and then this, and as you noted, this decrease. Do you have what contributed to that rapid rise? Was something specific going on? You alluded to perhaps social media, and then this fall off that occurred.
Yeah, I don't know if people really know the answers of why that happened, but they suspected that that rise was due to all of those dating apps that suddenly became available. And then it just may have kind of like a natural falling off. Yeah, I mean, I think a lot of the people that we interviewed, we found commonalities about, finding their, partners via one of the popular apps. So I think, that's what that NPR article is that, why are STIs going up? And I think that was the common thing that people said across the board.
Thank you. Now, as you also noted, and if anybody has any questions, again, please feel free. We have a couple of minutes left. With our residents, fellows, we rotate at the VA, both at the East Orange. Now we're expanding some activity with the Lions VA and geriatrics. We're looking forward to that this coming year. The opportunities to engage more fully or to understand more fully how to provide full sets of services between an academic medical center and the VA. Do you have any thoughts about that and ways we can? You mentioned about research. Are there other things we can do to collaborate more productively for the veterans in our area?
So I remember, even when I was at Fort Bragg and maybe 5 or 6 years ago, we sat down with the VA and just had kind of a discussion between on the military and the VA side. Hey, what are your areas of deficit? So just talking to them, do they have certain specialties that they need? What are they looking for? There was definitely an interest in research collaboration. I know the VA is very robust and looking to expand. So that's the first thing I would do is just kind of, sit down with leadership and say, hey, what are the areas you're strong in and what are you're weak in? But I just want to mention for people going to the VA, I know working with veterans, they appreciate, somebody having some familiarity with the military, saying, hey, what rank were you in the military? Where did you serve? And just having chit-chatting with them. They really appreciate that, especially some of the older veterans.
Yeah, thank you for that. That's a great message for all of us, and certainly for our residents who go over to the VA and are there on a regular basis. Appreciate that. Thank you very much. Dr. Bedno, I think our time is up. I want to thank you for really very, very informative and thoughtful discussion and presentation on public health and military and its implications for us more broadly. Really appreciate that. Thank you. And thanks everybody for joining. Really hope you enjoyed it as much as we did over here. And want to wish you all a great rest of the day. Thanks very much.